All right, hi there, everyone. So my name is Dr. Paul Bryan. I'm a family physician and clinical lecturer at UCalgary. I'm just doing a bit of a physiology review on some high-yield topics that are going to be covered in the upcoming resident review nights. So if you bear with me, I'll try to give you some helpful kind of practical tips, just some foundations for different physiological pathways that you're dealing with in a course for right now. So there's going to be a second video. So as you can see, I've made this lovely diagram uh, here on this whiteboard, and hopefully you can see everything. It's not important that you can read it all, but just to help guide me, just to explain some high yield things. And it's always helpful, I think, to write out some notes and do a form of what I've done here on your own if you feel like it's necessary in some areas. So essentially, I've got a super realistic man here with a few endocrine and renal highlights. And it's just to highlight some of the anatomical association between some of these physiological pathways. So what we're going to start with here actually today is starting by talking about some of these endocrine pathways like the thyroid, a little bit on the pancreas, and really just how it relates to the kidney. We're also going to go through lipids and then also the sex hormones and the control of the gonads, the ovaries or the testes, depending on male or female gender. So, sorry, I should say biological sex. Now, what we're also going to do is talk a little bit about adrenals. And then lastly, we're going to talk a lot about renal physiology. And we're going to build on this next time by going through some pituitary stuff. So stay tuned for that. And then also in the kidney, talking about electrolyte control with sodium, potassium, as well as some toxin handling like acids, nitrogen and ammonia cycle, and also just glomerular filtration and creatinine. So let's go through things. Let's get through it. So the thyroid to start off with. So I just really want to think of this super practically. So the thyroid hormone, what it does is it's a basic metabolically active hormone that has a lot of different effects in different tissues. But when you're thinking about what the thyroid is doing, the pituitary comes into this a little bit. And really what we can do is we can trust that the pituitary is making TSH in an appropriate way the large majority of the time. So usually there's a problem with the thyroid. And so what happens is the TSH stimulates the thyroid, and the thyroid has just three simple jobs. Number one is iodine uptake. And iodine uptake just means that however much iodine you eat, you're going to uptake more iodine. If you have it deficient in your diet, then you're going to try and hold on to as much iodine. So you're going to actually have hypertrophy of your thyroid gland. You're going to have a goiter. Now, next thing that it does is it gets stimulated to actually produce the thyroid hormone. The key thing here is that it produces a lot more T4 than T3. T3 is the active thyroid hormone that the tissues need in order to be able to be stimulated metabolically. They also then will choose to store and release T4 and T3. So in different disease states, there can be a problem with some or all of these paths or some of these functions of the thyroid hormone. And then once it gets actually produced at an appropriate level, it'll have negative feedback, as many pituitary hormones do, to TSH being produced in the pituitary. And then once we have release of the thyroid hormone at appropriate levels, what you have is you have normal cognition, you have normal autonomic drive, so things like your heart rate, your temperature. Then we're going to have GI motility like constipation, diarrhea, hair, skin, and nail growth. These are highly metabolically active tissues that can be impacted. And then menstruation, again, enough, they're just highly metabolically active tissue. So this is just the basic physiology of the thyroid, but it'll be a good foundation when you're thinking about abnormal thyroid tests and disease states. Now, next, what we're going to do is just talk about the pancreas a little bit. So the pancreas is just something that is the primary endocrine regulator of blood glucose. So when you look at blood glucose, it's important to be tightly regulated. So between 4 and 8, we're happy as can be. Now, if we start getting below 4, that's when we start releasing what are called counter-regulatory hormones. And the counter-regulatory hormones help bring up your blood glucose, but there are some side effects from these hormones. So as you can see, the first thing that's released is glucagon from the pancreas itself. And this is from the alpha cells, and it's the primary counter-regulatory hormone to try and bring up your blood glucose. But if you get below 4, you're also going to start releasing epinephrine from your adrenal gland to help bring up your blood glucose. And you're also going to release cortisol and growth hormone. Now, if you do get below 2, you die quite quickly. And if you're below 2, you're in a coma or seizing, and that has to be corrected very quickly. Now, if you go higher, it can also be dangerous. So that's why insulin is so important. If we have insulin, it allows us to avoid very high and inhibits DKA through lipolysis. So the pancreas has the primary 2 hormones that are controlling the blood glucose up and down. And really what these are doing is just trying to regulate this into a normal range. You can see how there's no backup for insulin. So if you lose insulin cells, that's why you quickly get in trouble and you present in DKA as first presentation of type 1 diabetes mellitus. Okay, so we're going to talk about how the diabetes impacts renal physiology in a little bit. But first, why don't we go to lipids? So the important thing to know about lipids is that there is a few key functions that are going on. So first of all, it depends on what you eat and what you're taking in and your ability to digest and absorb those fats. But really, this primarily impacts triglyceride levels, which are like an energy storage form of fats that your body will produce a lot of when you eat a lot of them, but then will eventually store or utilize for energy. So you can see here that really more digestion absorption will produce a lot of triglycerides if you have the ability to take them in and digest and absorb them. Now, if your triglycerides get above 10, you do get a risk of pancreatitis, which of course can be very serious. Now, the triglycerides often have an ApoC, which can bind to an LDL in the tissues, and this can release free fatty acids into adipose tissue. Now, if you have too much of this, this is what leads to obesity, a cardiovascular risk factor. You also have some triglycerides that through ApoE and the LPRP1 receptor on the liver, they get recycled and synthesized into other fats like cholesterol. So some of these fats that we have going through our circulation and that we have absorbed recently get recycled in the liver, and these bind through receptors. Now, what will be synthesized in the liver is they can synthesize triglycerides again, but this will lead to steatosis, which is again just adipose deposition in the liver, which can lead to NAFLD, another mild cardiovascular risk factor. Now, the other thing is that primarily makes this HDL, this is good cholesterol that goes back to the blood vessels and picks up that atherosclerosis, and then through ApoA comes back and recycles that cholesterol in the liver. Now, for LDL, this is really the bad cholesterol that leads to primary atherosclerosis, which is what we really care about. You know, there's a small caveat with some of these more mild, indirect cardiovascular risk factors through triglycerides, but primarily it's pancreatitis that we worry about as a major health impact. In terms of LDL, we really worry about this atherosclerosis. And so we have synthesis of LDL particles through the HMG-CoA, which makes cholesterol. And we can block this with statins and actually reduce the amount of LDL and atherosclerosis. LDL can also be recycled through an ApoB receptor on the LDL. And then there's an LDL receptor in the kidney that can bind to this and can recycle the LDL. So there's lots of examples of different mutations or different targets for drugs on these different receptors or different APO receptors, which are on the cholesterol or fat particles. But the key ones to know is this HMG-CoA inhibitor for statins, and then also the PCSK9, which will block the LDL receptor. And obviously you want more LDL receptors to be recycled so that you can bind more LDL and recycle it into the liver and make other less harmful cholesterol particles. All right, so that's cholesterol. That's the main thing there for physiology. Now, we're going to move on to some sex hormones here. So again, just as a little primer for pituitary coming up soon, don't forget that the hypothalamus will stimulate either the posterior pituitary or the anterior pituitary. The posterior pituitary actually has neurons that come down and store in the end plate the hormones of the posterior pituitary, which are oxytocin and ADH, and these can be stimulated through specific pathways, which we won't touch on today. Now, in the anterior pituitary, we have a thyroid releasing hormone from the hypothalamus, which goes to the bloodstream and stimulates TSH, and then TSH stimulates T4 production primarily and some T3 production in the thyroid. Now, it gets negative feedback and inhibition through T4 and T3. This also goes up to hypothalamus. Now, the hypothalamus will also release GnRH, which will stimulate the anterior pituitary to produce FSH and LH. And these have some complex negative feedback interactions. But essentially what you want to keep in mind is that most sex hormones will have a negative feedback inhibition, but it's not quite that simple. But essentially you can inhibit FSH and LH through a few things, including prolactin and other anterior pituitary hormones. So we're going to talk about ACTH, prolactin, and growth hormone on the next session. So coming back now to the ovaries, so what we have is we have a couple of different gonads. And the reason that they're different is because of the genetic genes that are carried on the sex hormones, X chromosome and Y chromosome. So if you have a Y chromosome, you have the ability to create the testicular tissue, which produces an androgen, a male hormone. Interestingly enough, the androgen receptor is on the X chromosome. So that means that if you have endogenous production, say from your adrenals, which also produce androgens, or you have exogenous use of androgens, then a XX genetic biological female can respond to androgen therapy because they have the receptors. There is a rare disorder mutation on these receptors where even people with an X and a Y chromosome will actually default to developing biologically as a female sex. Okay, so what do we have going on here then? So let's start with the ovaries. So with the ovaries, we have the FSH, which in the early phase of menstruation actually just starts stimulating an oocyte and has a very small increasing peak. This usually goes on for 7 to 21 days. It all depends on how potently that FSH can stimulate the oocyte to develop to produce enough of this estrogen to have a counter-regulatory impact, on the pituitary. So what we have here then is in the first set 1 to 3 weeks of menstruation cycle, we have estrogen being produced. This causes endometrial growth. And then once it is mature, there will be a complex hormone interaction that causes a sudden LH spike. This lasts for a very short amount of time, like less than 24 hours. And that causes ovulation of the egg out of the cyst that was being developed around that egg. Now these cells that are part of this cyst will actually become the corpus luteum, which produces progesterone. Progesterone will maintain the endometrial lining. And then if there is no fertilization and a sperm is not able to get here and produce beta-HCG, then the corpus luteum is not stimulated to continue. It becomes a scar known as a corpus albicans, and menstruation happens with sloughing off of the endometrial tissue. Now, if there is fertilization, beta-HCG maintains this corpus luteum, and eventually after implantation and placental development, a placenta overtakes both estrogen and progesterone production during the pregnancy. Now, just as a reminder here, if you don't have any androgen and you have progesterone and estrogen being produced by the ovaries, even though it's cyclical, there's always a basal amount that's there. And GnRH, that is the hypothalamic hormone that stimulates gonads, will actually be pulsatile and will vary over life stages, say like during puberty. So you have a very complex interaction in these gonads. But what we're trying to create is an oocyte estrogen to create a viable endometrium, and then maintain that viable endometrium with a progesterone, and then get rid of it if we're not going to run into a fertilization of that egg. Now, what we have here is a little bit different in the testes. There's a discrete role for FSH, which is to stimulate Sertoli cells and spermatogenesis. And then we also have LH stimulation on Leydig cells. So Leydig cells are actually what produce testosterone. The environment of testosterone is needed to produce sperm. So both of these are needed, even though it doesn't directly stimulate sperm production. And then testosterone, if the receptor is present, will be dominant, and you will not then default to a female or a female sex phenotype, but you will actually be a male sex. And the other thing to keep in mind is that the adrenals, which are stimulated just through a different pathway, ACTH, this is a different anterior pituitary pathway, which is inhibited through cortisol. That's because the cortex of the adrenals, which is all stimulated by ACTH, produces aldosterone, cortisol, the negative feedback inhibitor, and then also androgens. Now, if you have overstimulation and hyperplasia of the adrenals, which can happen, what you can get is you can actually get androgen production that can create hypermasculization in young males. Think of this as basically like a precocious puberty from the androgens. Or you can actually get a female that starts having male sex characteristic changes even at a young age, like an infant that's born with ambiguous genitalia. So this is important to keep in mind, that the adrenals are also part of the sex hormone pathway, but really they just produce androgens through a separate pathway that can become pathologic. The key thing here is GnRH in the hypothalamus, controlling complex, unique FSH and LH release, which interacts with different cells depending on what gonad has developed. And this is all dependent on the genetic underpinnings of sex chromosomes and the androgen receptor present on the X chromosome. Okay, so that's pretty much everything there. So now what we're going to talk about is the renal physiology a little bit. So what I've done here is I've just zoomed out, and a key thing that you want to keep in mind is how closely associated this adrenal gland is. And that's important because these are many hormones that are stimulated or important in renal regulation. So aldosterone, important in the RAS system, and also responds to potassium concentration to help excrete potassium in the distal nephron. We have cortisol, which is important to potentiate vasoconstriction. If you do not have any cortisol, you will be very hypotensive. It's called adrenal insufficiency. And then you have androgens as well here being produced in the adrenals. And this is somewhat of a unique one, but this is like the stress response that's trying to be stimulated from the adrenals to give you more androgens. And then lastly is the medulla, which is epinephrine, and again, can be a potent stimulus for volume control, which the kidneys are very integral part of. So the adrenal gland has these small adrenal veins and arteries that actually come directly from the kidney. So if you get release of these hormones, then you're going to get very potent and very direct communication, and effective communication between the different components of the RAS system in the kidney and in the adrenal gland. So you're going to want to think about how these ones are connected just in the most simplest way. So let's talk about the kidney. So we've scooped out a piece of the kidney. And remember, this is just a proportion of your kidney. I like to think of the kidney as like a field of wheat now. And so there's different vulnerabilities in different species within that field. What I've drawn here is a single nephron to just highlight how there is similarities between these nephrons, but each of them will be at a different stage. And this is important to remember because we can actually lose an entire kidney and our kidney function would not change. And so there's a lot of surplus in this field. And what we actually start seeing when we start seeing disease states is a minimum amount of injury to the nephron. So this is just part of the nephron here. We've got the cortex up top and we've got the medulla deeper here. Now what we have is we have a blood vessel coming in. This right here is a sphincter. Now the vasculature of the kidney is very similar to other vasculature in many ways, but also somewhat unique. And one of the unique things is this afferent arteriole. So this afferent arteriole that comes before the glomerulus can actually be controlled by different vasoconstrictor hormones like the RAS system. And so you can adjust how much pressure is getting to the glomerulus. Now they also have an efferent arterial sphincter, which this can clamp down and increase the pressure behind and create, like a dam effect, and that'll increase the glomerular pressure. Now, what we want to do is we want to have tight regulation of this pressure because we're using this part of the kidney, or the nephron, I should say, as a filter to push through toxins. And we want to make it a filter so that we avoid getting rid of good stuff. So right here in the Bowman's capsule, we have a very close-knit association of a filter with these podocytes, which are part of actually the Bowman's capsule epithelium itself, as well as the endothelial vasculature of the glomerulus of the blood vessels. So this is a very fine blood vessel. And so it's a micro vessel and it's susceptible to injuries that other microvessels may be. And that's important to keep in mind. Now, when the kidney's working normally, what we're able to do is filter out things like creatinine. That's why creatinine gives us such an effective and reliable measure of the glomerular filtration rate, because it's primarily excreted through the glomerulus here. We also get rid of some ammonia-based things like, or some nitrogen-based things like ammonia. We get rid of certain acids, certain metabolites, but we'll also get rid of a bunch of water, a bunch of electrolytes, sugar, and other nutrients that we may want to hold on to. So the first thing that we do is we go to the proximal convoluted tubule, and this is the workhorse of the cell. It has the most metabolic demand. It actually responds very potently to angiotensin. So when the RAS system is increased, we're going to have potent release of angiotensin, and we're going to have, sorry, no, I'll just fix that. And we're going to have angiotensin upregulate the proximal convoluted tubule. We already have about 60% of our water reabsorption. And remember, water and sodium, the most common electrolyte, follow each other and go together. We also reabsorb bicarb here in the proximal tubule, and we can eliminate this reabsorption through the diuretic carbonic anhydrase, which is not used very often anymore other than for altitude sickness. We also have sugar being reabsorbed here, and this sugar can be reabsorbed through SGLT2, and we can inhibit this transporter in diabetes as a treatment. Now, if we have a blood glucose greater than 11, then this will actually overwhelm the proximal convoluted tubule, and we'll start losing valuable glucose in our urine, glucosuria. So now we're at the proximal convoluted tubule. We've reabsorbed as much valuable things as we can. We haven't filtered out proteins and cells like red blood cells. If there's a problem with the red blood cells, if there's a problem with the endothelial lining of the glomerulus, we'll get red blood cells and other cells in the urine. We also, if we have disruption in the podocytes, we'll get protein that slips through our filter. And this is actually one of the earlier parts of microvascular disease from diabetes in the kidney. So first we get RAS activation due to hyperfiltration. And this is because some of those nephrons in our field of nephrons are actually sick, but not enough to impact our kidney function. And instead, what's happening is that those sick nephrons are releasing RAS. They're activating RAS, releasing renin, and then the other healthy proportion can actually overcompensate and you get hyperfiltration. It's very difficult to pick up clinically. Next, you get proteinuria, and this is the podocyte dysfunction and injury caused by diabetes. Lastly, we get glomerular sclerosis. We get scarring down of the blood vessels. We get no longer have good filtration through those nephrons. And if we reach a significant proportion of those field of nephrons, then we will start seeing chronic kidney disease and its complications like accumulation of toxins, uremia. So now what we're doing here then is we get through the proximal convoluted tubule. There's some fine secretion, so secreting out some drug metabolites, like some antibiotics in the proximal convoluted tubule. But once we come on down to the loop of Henle, we're actually diving deep from the cortex, the outside of the kidney, to the medulla. And the medulla interstitium becomes very, very salty, has an osmolarity of around 1200, where our blood serum has an osmolarity around 300. So what happens is as the loop of Henle goes deeper and deeper, some of these are actually specialized and go very deep. They have from the descending small tubule reabsorption of water, and it's just that salty interstitium pulling it out. We get about 25% of our water and salt reabsorption from the loop of Henle. Now, what makes the salty interstitium is actually the loop of Henle's engine, which is this NK2Cl transporter, which is the primary transporter in the ascending loop of Henle. And this uses a lot of energy as well to reabsorb as much electrolytes as possible. And it often not only gets reabsorbed into the circulation, but stays in that interstitium of the kidney and makes the medulla extremely salty. This is blocked by furosemide. So that's why furosemide will make us pee more. We reabsorb quite a bit of water, 25% through this part of the kidney. And it also is what makes our medulla salty. So we'll lose our ability to concentrate our urine, which we do in the collecting duct. So the loop of Henle comes on up here, and then we have the distal convoluted tubule. The distal convoluted tubule and primary transporter is the NaCl transporter, co-transporter, and it is blocked by thiazides. Now, this is the fine-tuning area of the kidney. As you can see, it only reabsorbs about 10% total volume of water and electrolytes. But it also has an important role in calcium. It can also change the handling of uric acid secretion in the kidney. So the fine-tuning of uric acid in the context of gout, or fine-tuning of calcium in the context of hypercalcemia, can really be an important thing to consider with thiazide diuretics. Now, with thiazide diuretics, you do not get the salty interstitial washout. So that means you still have a potent collecting duct, which works well. Now, something that's important to keep in mind is that there's an apparatus called the juxtaglomerular apparatus, which is in the near the glomerulus of the nephron, but it also closely associates with the distal convoluted tubule, and it senses flow, and it senses how much electrolytes and water is going through the kidney. Now, when it senses too much flow, it's worried that it's losing too much, so it's going to upregulate renin, right? Or if at the glomerulus we have really poor glomerular filtration, it will also upregulate renin. So it's going to try and have a good pressure at the front end to get toxins out, and then have a really good ability to reabsorb as much water, nutrients, and electrolytes so that you have low flow by the very end of the distal convoluted tubule. Now, you want to do most of your work here because the distal collecting duct really can only absorb about 5% of water, but this is variable depending on the hormone regulation. So the distal convoluted duct has a principal cell, which really has two primary transporters that are controlled by hormones. The first is the ENaC channel. This is the epithelial sodium channel, which is stimulated by aldosterone. What this does is it puts a sodium into the apical membrane of the nephron, and it actually allows sodium to be reabsorbed. Now, we can block aldosterone and this ENaC channel through potassium-sparing diuretics like spironolactone, which blocks aldosterone directly. Now, the other transporter is the ADH aquaporin. The more ADH that we're releasing, either due to being hypovolemic or due to being hypernatremic, or because of RAS activation and poor kidney perfusion, we're going to put more aquaporin into the distal collecting duct. We're going to reabsorb water, but again, this is just some fine-tuning, that extra squeeze that we want to try to get. Now, when we reabsorb that sodium, it allows us to kick out a potassium to replace that positive charge, or the intercalated cells can also release an acid, right, or a hydrogen ion to replace that positive sodium that was kicked out through the ENaC channel. Now, as you're going deeper into this collecting duct, you have principal cells that are putting in aquaporins all the way down into this really salty interstitium. So you can eventually make urine that's close to 1200 osmoles. Okay. Now, what you hope to do is peel the toxins like the creatinine that we can measure in the urine, urea, etc., nitrogenous compounds. And then you also will have a sodium concentration. And if you haven't had to reabsorb every ounce of sodium in there, then that probably means that you have pretty good effective arterial blood volume, good perfusion to the glomerulus, good GFR, you're well hydrated. Now, if you have an osmolarity of your urine greater than 300, that means that ADH is on. That means you've been having ADH putting aquaporins in your distal collecting duct, and you have had concentration of that urine to above 300 osmoles, and that's required, or ADH is required in order for that to happen. Okay, now let's just quickly talk about like why does the kidney all do this, and then we'll be done for the evening. So the kidney does this because it has a couple priorities or a couple things that it really wants to do well. Number one is volume control. So when you think about volume control of the kidney, really, you're thinking about intravascular volume,
firsthand. But this is related to the other body compartments that hold fluids and electrolytes as well. So as you can see, if we just take an average person, say they are about 35 liters of fluid or water in their body, about only 3 to 5 liters, about 10% of that, will be actually in the blood vessels itself. And most of it will be in the veins, because that's really our storage system that has a lot more elastic compliance and can hold on to that extra pressure, because it's a low pressure system. So it's going to be more easy to accumulate there. The high pressure arteries are going to regulate that pressure and keep the volume somewhat similar. So what we really are talking about is, number one, intravascular volume control. And we do the renin, angiotensin, aldosterone, ADH, RAS system to activate this. So if we have low blood volume, if we have poor perfusion, low EABV to the kidneys, you're going to sense that in your juxtaglomerular apparatus. You're going to release renin, which is going to directly stimulate angiotensin, which is a vasoconstrictor, a stimulant for the proximal convoluted tubule. You're going to get aldosterone released, which is going to reabsorb more sodium, kick out more potassium, and reabsorb more water. You're going to have ADH that reabsorbs more water through the distal collecting tube, through the aquaporins that it inserts to the collecting tube, or collecting duct, I should say. And all of this is going to help increase the blood pressure, increase the vasoconstriction of the arteries. And that's why you have big, thick muscles that respond to these things in the arteries. And then you also have this sphincter, just like the kidney does before and after its glomerulus, right before capillaries. And that is the autoregulatory arteriole. So what this does is makes consistent blood pressure through the capillary. And in the tissues, we want to get the toxins out of the tissues into the bloodstream. And we want to get the nutrients out of the bloodstream into the tissues. This is the opposite of what we're doing in the kidney. We're getting rid of all of these toxins from the bloodstream, putting them into a storage container, the bladder, and we're reabsorbing all the nutrients back into the bloodstream so it can be brought to the tissues and be reused. So what we really want to keep in mind then is that intracellularly, there is the most amount of fluid in the body, but we want to regulate how much fluid we have going into different areas. Edema, which is extra fluid in the interstitium, can be a problem. And we've talked about the reasons that this happens. It can be a problem with the proteins like albumin. It can be a problem with the hydrostatic pressure in the veins, increasing body volume of water. It can be a problem with the integrity of the blood vessels themselves, or the veins, I should say themselves, like, venous insufficiency with poor valves, or it could actually be something like sepsis that causes capillary and venous leak from the endothelium. So really the key thing here to keep in mind is just how the kidney has a bunch of different ways to make sure that this intravascular volume is prioritized. Now, the sodium and potassium concentration from the interstitium and intravascular are very similar to each other. So the kidney doesn't actually have the ability to only put fluid in the arteries. So when it tries to compensate, it will usually overcompensate and tolerate some edema, extra fluid in the veins, which then leaks out into the interstitium, because they're very similar in their pressure and also very similar in their osmolarity and electrolyte constitution. So it's these other factors that play a big role in how the fluid moves through those systems. Now, interesting enough, in the intracellular, it's just important to keep in mind how there's higher potassium intracellular and lower sodium. So these are electrolytes are relative toxins or relative nutrients, depending on the needs of that tissue and of that body compartment. So that's number one, is volume control. Make sure that we get intravascular volume well controlled. If we need to, get higher body volume by reaccumulating salt and fluid, it'll leak out into the interstitium and cause edema. And then we also want to make sure how this impacts the tonicity of our cells, say like when we're rapidly changing our sodium or rapidly changing our glucose levels. So that's number one. Number two would be electrolyte control. And we're going to talk about this more in part one, and we'll talk about more of the electrolytes and more of these transporters in the kidney and how they are sensed and how they are controlled. And then lastly, we'll talk about the filtering of toxins. So we'll talk about glomerular filtration rate and creatinine and glomerular diseases. And then we'll talk about nitrogen and ammonia handling, which is closely related to acid and base handling in the kidney. All right, that's everything. If you have any questions for me, please do feel free to reach out. I hope that you have an awesome session coming up here soon, and part 2 will be coming up. Thanks for listening.